pleasure in having you all over here for our webinar number 2 on big challenges for small, medium, and large healthcare organizations, perspectives for a new normal world. Today, I am joined by an expert panel, power-packed speakers who are going to talk about the various challenges and how it is going to be overcome in the new normal world. Without further ado, let me introduce them. I take great pleasure in behalf of Global Mantra and QurHealth in introducing each of the speakers. First up, we have Dr. Arun Mahadji Sitaram. He's an associate professor at Ramaya Medical College and assistant hospital administrator at Ramaya Memorial Hospital. He's an experienced hospital administrator with a demonstrated history of working in the medical operations. He's highly skilled in hospital operations, hospital planning, quality management, and strategy. He has a very strong educational professional with a Doctor of Medicine focused in healthcare administration with a management from Kasturba Medical College, Manipal. Currently, Dr. Arun is an associate professor, as I said earlier, and it's a beautiful campus. And I've been, as part of being in Bangalore, I visited the campus at multiple occasions, and it has been fantastic the way they run the show over there. A lot of conferences I've been there. Thank you for having me there, Dr. Arun. Your opening comments, Dr. Arun.
Thank you. At the outset, let me thank Rajarajan, Global Mantra, and QurHealth for inviting me as a speaker for this, for the webinar. To start with, I think we are all in the midst of the pandemic. Many of the countries have hit a peak, and they're now in the downslide, whereas we still do not know are we reaching the peak. In the midst of all these confusions, the economy has opened up. The hospitals have, they never closed, in fact, but the regular normal operations have resumed. So there is still a lot of confusion among people, especially patients, as well as the healthcare staff, in terms of how do they see every day when they come to the hospital. So probably we can, going forward, we will have a lot of insights in terms of what are we doing at Ramaya and what are some of the best practices that we are looking at, and some of the shared knowledge that we can probably throw up to the audience, and then we can look at that is what my opening remarks is.
Thank you, Dr. Arun. We have a pleasure of having your company today with us. Next up is Dr. Vijay PV. He's a partner and senior consultant with Integra Ventures. So Dr. Vijay, after graduation, has worked as assistant administrator in the corporate hospital in Coimbatore. Then since he developed more passion for healthcare management, after that only he had done his post-graduation in hospital management. He has led a lot of hospitals for implementation of NABH standards. He worked as a deputy manager quality for a Hyderabad-based consultancy, where he was handling about 7 different NABH projects, and he was also instrumental in setting up the Hyderabad branch office. He was later associated with Medica Synergy, and especially on related to turnkey projects as a regional coordinator. He also handled business development activities in South India for Medica Synergy, and he has also a great experience in brand building activities. He was part of the corporate team working for organizations for next round of funding as well. Later, he joined SIMS Chennai as commissioning coordinator and was completely instrumental in commissioning the project. He's the man behind the 250-bed Harvey Hospital, Aster Harvey Hospital here in Bangalore, and he was in charge of the project from paper to patient. He also is working as a project consultant currently with MGM Healthcare Chennai, and they've been doing some phenomenal projects. I've had the opportunity to visit some of the projects. The amount of knowledge and discussion which has gone into combine the good practices and the new normal things is very, very evident, and I'm sure you'll be seeing those in his presentation. Welcome, Dr. Vijay. Over to you for your opening comments.
Yeah, thank you, Raj. It's a pleasure to be on this platform. So today I would be just sensitizing everybody. What is infrastructure going to? How is infrastructure going to play a role in this infection control, and what would be the new norms so that at least infrastructurally we can minimize a lot of infections and cross infections. So we'll take it forward in the present.
Thanks, Dr. Vijay. Next, we have with us Professor Dr. Ashok Tyagarajan. He's the CEO of Westminster Healthcare Chennai. So, Professor Dr. Ashok Tyagarajan is graduated in science, pursued labor law and MBA from Madras University. He went on to get awarded with MPhil and PhD in management with Bharatiya University, Coimbatore. He has over 3 decades of professional experience in various healthcare organizations at various different roles: sales manager, branding head, general manager, vice president, and senior vice president. He's a person of very rich resource. You can listen to him talking days and days together. He has served in some of the leading organizations like Cipla, Beiersdorf, AG Germany, Johnson & Johnson, the USA, and assisted over thousands of surgical procedures across the globe through all his stint with his pharma and surgical companies. He went on to lead the bioceramic surgical devices division with Murugappa Group and was a part of the multi-center clinical research team of MS Ramaya Hospital in South Africa, Philippines, and India. So he has been at the helm of affairs in various hospitals throughout his career, and we are very happy to have you, sir. Over to you for your opening comments.
Thank you very much, Rajarajan. It's a great pleasure and honor to be a part of this wonderful team of experts. And first of all, I would like to thank QurHealth for giving me the great opportunity. And as our expert key opinion leaders have rightly pointed out, we are sitting at a time where the pandemic has posed a lot of challenges and questions. Everything is being tested, from our mental strength to the physical strength, and everything is being tested. So I'm also looking out for the great opportunity to listen to the experts and also to listen to the viewers or the attendees regarding their questions and to share my little knowledge that I've gained over a period of 37 years across the globe. Thank you very much.
Thanks, Professor Dr. Ashok. Next, we have with us Mr. Ramesh Balasubrahmanyam. He's a CEO, CBCC India, and Director of Apollo CBCC Cancer Care, Gujarat. Mr. Ramesh Balasubrahmanyam is a graduate in management with specialization in labor laws and industrial relations. He has been in the hospital industries for over 23 years and has worked with premier institutions such as Aditya Birla Healthcare, Apollo Hospitals before joining Comprehensive Menin Cancer Centers back in the year 2008. Mr. B. Ramesh is known for his rich business acumen in various spectrums of healthcare management and delivery. He has received wide accolades from different quarters and recognition with all his previous employers, leading them from the helm of affairs. Mr. B. Ramesh is a graduate in business administration and also has completed his bachelor's in law. So it's a pleasure having you here, sir, leading a cancer center, multi-center cancer center across India. Happy to have you here. Over to you for your opening comments.
Namaste to all of you. Thanks, Raj. Thanks, QurHealth, for this opportunity. As all of us said, we are amidst pandemic, and I think we are gradually getting used to it. We are only now. I think it's definitely, yes, new, but I don't know whether it has become a normalcy. We are just testing it now. And one of my hospitals is a COVID hospital. So I have the other one is a non-COVID hospital in Gujarat. So both I have the experience, hands-on experience of how both these hospitals are affected, rather impacted. I won't say affected. And it'll be my pleasure sharing my experience and my perspective on the new challenges going forth in the new post-COVID era or along with COVID era. So that's going to be our take today. I'll be very keen to listen to my fellow panelists also, and let's hope for a very interesting session. Thanks, Raj. Thanks, gentlemen.
Thanks, Ramesh sir. So it's been a pleasure to have you all. Okay, so yours truly. So I'm a healthcare management professional, been associated with various multi-specialty hospitals, oncology, cardiac hospitals. Currently, I'm with Global Mantra Innovation, and I lead the QurHealth India division from Bengaluru here. And we will just before we start, we'll give you a brief of what we are doing at QurHealth before we start hearing from all our panelists. So QurHealth India is a division of Global Mantra Innovations. Global Mantra Innovations is a research and innovation center for Ventech Solutions, inclusive USA. So our vision is to empower healthcare ecosystem to generate value through the data. So we want to save lives super proactive. That's our mission. So we are a 150 million US dollar company. We manage about 800,000 providers in the US, along with 800 dialysis centers. We have all their clinical healthcare data, claims data, about 43 petabytes of healthcare data, making it one of the largest in the globe. So we have a very strong leadership team, and we have about 700 team members in US and India put together. Unlike many other companies, we have 600 people sitting in the US and about 100 of us sitting here in India. Our company specializes in biostatistics, data analytics, natural language processing, NLP, deep neural network, AI, artificial intelligence, and machine learning. Our platform which we are bringing in is a scalable multi-layer architectural platform, and through QurHealth we have a solution for hospitals, which is goFHB, where we help hospitals to digitize their data and start the digital revolution. And all the patient records are provided to patient over an app, wherein they can download this app, which is readily available currently at the Play Store, and have access to all their apps, and also various other plethora of features related to healthcare. So I take great pleasure in introducing my company, and we are one of the largest contractors of federal health and the defense health in the US, that which gives us a lot of importance for confidentiality, privacy, and security and stuff. So without further ado, let us get on with the day's program. I invite upon Dr. Arun to take over the helm to start the proceedings for the day.
Thank you, Raj. I think your company is doing a really good job in terms of digitizing records. And as I, make my comments in the slides, digitization of health records and so to start with the slides, my topic today is a new normal in medical services, clinical operations, and quality. As we all know, countries altogether is, we are all facing a global pandemic, and there's an unprecedented crisis that we are all facing. And the healthcare response to COVID-19 is something that is going to be there for the next 18 to 24 months as countries grapple with rising cases, deaths, inadequate testing, and then the lookout for new therapies. So going ahead for the next 18 to 24 months, we have to coexist with this this particular pandemic, and there's no other way out. So whatever we talk about normalcy is something that we can see say the new normal. The definition of new normal is changing every day. So it's very dynamic. Just like each day, the government comes with its own set of regulations and policies with respect to how are you going to go about doing the testing. What are the what is the nature of testing? So still we are doing with RT-PCR. We still do not have the spot test and other things. So there's the hospitals and administrators, they need to be really agile and adaptable to these kind of fluidic situations. See, one thing that came about during this pandemic is how are we screening our patients? See, screening and triaging of patients was more connected with emergency response and probably as part of your health check thing. But now slowly hospitals and doctors have started to realize that, okay, here is a mechanism where they're going to screen patients not only for say COVID, but also for other illnesses also. And this screening is acting as a digital first door. Okay, it's sort of a nowadays patients are not just like walking screening, especially through use of apps, is acting as a digital front door for the hospitals. And as you can see, the use of Arogya Mitra, which has been now made mandatory by the government. Likewise, there are other app providers also who are providing this so-called surveillance tool, or what we call as a symptom checkers. This is not something which is new, especially if you look at most of the Western hospitals like Mayo Clinic or Cleveland Clinic. They have something called as symptom checkers in their websites, where patients can check for their requires OP a visit or anything of that sort. This is something that many of the hospitals are now going to adapt and will be the new normal. And this is also a part of the new normal, what we call as a proactive management, and also empowering patients. So you're giving access to patients to a lot of information where they can check upon themselves how healthy they are, and then if the severity of the illness requires them to visit a hospital, or they can manage over a telephonic call or a video consultation, is that we call. So there are a lot of app developers and including agencies like, or organizations like QurHealth can provide a lot of these tools which are based on artificial intelligence and machine learning and otherwise. So a large digital repository of data is as such required. If at all you need to give a near accurate diagnosis based on the symptoms that the patients are going to key in. So this also throws up a very different engagement level that the doctor can have with the patient, because as such doctors used to face patients who would come with knowledge that they derive from a lot of online resources like Google and otherwise. Now with information explosion is happening, especially with the corona thing. So everyone is accessing the internet to find out about the diseases and otherwise. So this is something that will be a new normal, where every patient will now hook onto the internet to know about the diseases before they come to the doctor. Be more intensified and across the spectrum. As I said, with the new concepts of telemedicine, virtual consultation, and remote monitoring coming in place, the engagement of the doctor that he has with the patient will now be more of a virtual level. And the concept of digital doctor is something that is it's already gearing up shoots and will be a new normal in the coming days to come. So there'll be a situation where virtual reality, augmented virtual reality, everything will be in place, and the level of digital engagement will be enhanced. So in terms of doctor-patient relationship, likewise before the crisis situation, the doctor-patient relationship had hit a low, especially with the situations of wherein there was over specialization of medical care, over commercialization of medical care, doctors spending less amount of time counseling and educating patients and all those things. And this pandemic actually has given a global, sort of a golden opportunity for doctors to correct this, and then sort of create a more positive relationship with the patient. See, what we have seen is that many of the patients who are it's not only for information related to corona or anything. They're just talking to not only with related to their disease, but they're also wanting to exchange a lot of information with the doctors. And at this point of time, especially during the lockdown period, where they could not access healthcare, come to the hospital and otherwise, they felt they really missed their doctors. Many of them who have been coming regularly to meet their doctors. This sort of is a good opportunity for us to reconnect well with our patients, because ultimately we need to realize that, but from the whole point of view, the emotional well-being, the social well-being, everything, which was possibly missing, and this pandemic created an opportunity for us to correct this scenario. And also the situation is such that, okay, especially during the COVID and then in the next few months, it so happens that there is a restriction on the number of patients who can visit the doctors, and then the doctors wearing personal protective equipments and with limited examination of patients. So this is again gives rise to a situation where the patient is not fully satisfied with the care outcomes. See, most of the times we have seen that though the patients get a telemedicine consultation, they're still not very happy. They still want to come back to the OP setting, talk to the doctor, get examined by the doctor, and that gives a sense of satisfaction to them as well. Other thing that we're noticing is also the avoidance of unnecessary visits. See, there are already players like home sample collection by the laboratories, the delivery of medicines by companies like PharmEasy and otherwise, and this is something that is has seen a greater traction and acceptance. So hospitals also are looking at how this is playing across, and how they can probably redesign their spaces, because we have seen that there is a close to about 30 to 40% reduction in sales of outpatient pharmacies. And second thing is there is also increasing request for home sample collection. So going ahead, there'll be a shrinkage of spaces, especially with related to the outpatient pharmacy. The lab sample collection that we have in the hospitals has more patients who would otherwise come to the hospital for possibly a prescription refills, or for a follow-up of investigation. They would not come to the hospital only for this. They would rather access a doctor virtually or a teleconsultant, and they can fix up a home sample collection by third-party provider or from the hospital per se. So this has resulted in less number of footfalls to the hospital also. It's a good thing as well, because just like in airports, anyone without a body card is not allowed. So the same situation will now be in a hospital, where patients are generally not walking into the hospital at all. There will be a greater acceptance of digital healthcare. Hospital and healthcare was something that was very lagging in terms of adoption of healthcare. If you look at electronic health record, electronic medical record, even in some of the advanced countries in Europe, West, there is less acceptance among the doctors towards electronic health records and medical records per se. But now the situation is such that where there is a fear that the virus stays in stationaries, paper records, everything, and to make the operations more contactless and less number of steps, there is a greater adoption of electronic medical records. And also everyone has realized that data is something that is very important. So they need to make certain evidence-based decisions. So they require a lot of data that gets keyed further into the clinical decision support systems. Based on that, doctors are now making decisions. As we have seen, the corona is something that hit us really hard. There was no previous precedent to that, and then go about diagnosing the disease. What are the treatment protocols? What are the outcomes? What are the long-term implications of this particular disease? No one knows. So everyone has realized that, okay, this pandemic is here to stay, and we will be grappled with much more pandemics in the years to come. So there is a growing interest towards usage of digital tools to record data and also to analyze data, not only helping them in terms of clinical decision, but also looking at in terms of future research as well. And I think this is where they are digitizing medical records, and this data is also accessible across various platforms by the patients also. This is what we are looking at. And as I told you, like, as more people do not come to the hospital, doesn't mean that care is compromised, or the people are not looking for care in the hospital. There is a growing interest towards remote monitoring, home care and otherwise, especially among the geriatric population. We have seen, among the high net worth individuals, they have been requesting hospitals where they can stay in the hospital, but where they can virtually access the doctor, and the doctors can also access the records. And this is where devices which can be connected over internet come in place. There are organization with systems and otherwise, where we have placed in a couple of patient places, and we have twice a day visit to their hospital by the nurses. But the doctors are, seeing the records, monitoring their vitals virtually. So there is a growing acceptance among these kind of technologies among people. So whatever technology that we say, unless the patients accept this and there's a trust level in these technologies, there'll not be a great adoption. But during this pandemic situation, we have seen this, where personal data also. How do I change the next slide?
Slide is changed, Dr. Arun. Go ahead.
Can I? Okay. As we were talking about, evidence-based and protocoled healthcare is something that is going to stay. This is nothing new in academic medical centers, where as part of our teaching learning programs, we do go with the evidence-based and protocol healthcare, and but not necessarily in a corporate hospital. But many of the consultants have come in terms with that, especially we have a lot of disease conditions which are mixed up with corona, and then throwing up new symptoms, and with no clear-cut diagnosis and otherwise. A lot of consultants are dependent on shared knowledge. As we have seen in the last couple of months, millions of research papers have been published, especially with respect to outcomes and all. So shared knowledge, which was otherwise limited to a particular institution, is now getting opened up. So there is a large repository of digital information that is being created, and also an access. See, even if you look at some of the journals which were subscription based and otherwise, they opened up their journals to free access. So this free access journals and free access to knowledge repository will be the new normal. So a lot of evidence gets gathered, and everyone will now be interested to put across their clinical findings here as well. This is a good thing that has come out of this pandemic. Second thing, what we're looking at is, most of the consultants will base their diagnosis and treatment methodology based on the clinical autonomy. They always prefer clinical autonomy. But here is a situation where that had to be sidelined. As I told you, everyone looked up to trusted sources for information on symptoms, for information on treatment protocols and outcomes and all those things. And this is going to be the government. It insists on certain standard treatment protocols, but that was not getting followed. But now this will be a part of the new normal, where standard treatment protocols and guidelines will overtake, or will be more given more importance than the clinical autonomy that the consultant prefers. Other thing is that with a lot of data coming in, there's a growing impetus towards research, clinical trials, and innovations. You can see everyone doing about an innovation. An automaker is building ventilator. The fashion brands have come with, they're making PPEs, masks, and hospitals are getting built in record time. So these are the kind of innovations that brought about during the times of COVID, and this is going to be the new normal, where as you see, the concept of shared ventilator came, where a particular ventilator device could be connected to two different patients. Otherwise, a hospital would have to purchase. So with a little small innovation that was brought in, cost optimization was achieved, and all those things. So this will gain acceptance going ahead as well. So if you look at today's newspaper also, especially in terms of clinical trials, there was a lot of regulation and a lot of clinical trials were moving out of India. But now Niti Aayog has told that, okay, there is going to be a much more streamlined and smoother regulation with respect to clinical trials. And this is something that is the pandemic has taught us, that unless you are prepared, unless you are agile, unless you are looking out for new knowledge, you will be really hit hard when the next pandemic comes. Redesigning concept of hospitalization, I think Dr. Vijay will be speaking, but since I have also put in my slides, I'll just take a few minutes on this. Continuum of care model, which was existing earlier, and somehow after the corporatization of healthcare that happened, patients would be seen in the OPD. Patients would, patient would be seen in one place, right from OPD to intensive care to the convalescent care. Everything used to happen in one place. But now again, patients are looking at not coming to the hospital except for an emergency or an acute care. So they're looking for a more safer comfort care setting or a nursing home setting for their moderate and mild illness. This is going to be the accepted norms later, and accordingly a lot of design changes will also happen in the hospitals. They find that, okay, this also prevents the mixing up of cases, especially when it comes to communicable diseases. The ongoing chronic care, especially the chronic dialysis, requirement of chronic kidney patients who require dialysis, otherwise can be probably put up in a nursing home setting as well. So something that will gain precedence in the coming days. And a lot of ambulatory care settings. See, we had a model which was there 5-6 years back, where they introduced the concept of daycare surgery and a boutique hospital. Somehow it did not get traction then, because patients still felt that was not a hospital. But now, including hospitals, doctors and patients have a unanimous opinion that, okay, some of the surgeries need not be done in a regular hospital setting, can now be moved to an ambulatory care setting or a daycare setting. And the concept which was brought 5-6 years back, probably that was ahead of its time, but now it's quite the right time for someone with a particular ambulatory care setting as a business model to come in now. Provision of isolation facilities, engineering controls. A lot of hospitals had to retrofit their ICUs, OTs and all to prepare for the negative pressure. Likewise, this is going to be a new normal, where every hospital will identify certain spaces where they can take such cases, the infected cases and otherwise. And then there's going to be a concept of dedicated communicable disease hospital. We had this earlier. Even now we have spaces dedicated for leprosy, tuberculosis and otherwise, as part of to avoid the social stigma. The concept of communicable diseases hospital was not encouraged. But now with this pandemic, and then the concept that, okay, the infected cases are to be treated separately to avoid mixing cases, there'll be a day where the communicable diseases hospital will be a separate entity by itself, rather than as a part of a hospital setting. Can we move to the next slide? So in terms of clinical operations, it has been very challenging right from the day of pandemic, and in every day we are facing a situation. The most important aspect of the clinical operations is creating a positive patient experience. This is something very challenging and troubling these days, especially with the onset of corona, with the onset of concept of screening, triaging and otherwise. There's longer waiting time that the patient has to face. As I told you, the concept of triaging has been brought in, where a patient is not necessarily allowed to go to the specialist directly, where he is first triaged by a junior resident or a general physician before he is sent to the specialist. This is going to be the new normal. One important aspect of patient care that really was stressed during the pandemic was patients' access to information, or the right source of information, especially with respect to their disease conditions, to their ongoing treatment regimens, and otherwise. So many of the patients were looking up for a lot of information. So this is when many of the hospitals created websites or link in their websites, where patient could get information from trusted sources. As you can see, I've put it in the slide also. This is one thing that was done by Cleveland Clinic, where they could patients from Cleveland Clinic could gain access about information related to the coronavirus. They could get information about their own disease conditions, and then probably set up a virtual consultation with the doctors as well. That's one thing that is we are looking at in terms of how do we look patient care executives who look at counseling as a separate aspect as well, to enrich the patient experience who are coming to the hospital. Supply chain management, this is one thing that got disrupted very clearly, and then many hospitals who were earlier following the just-in-time inventory. Just-in-time inventory is something that came across as a wave of quality and efficiency, and likewise where hospitals looked at keeping a very less stock of items. The logistics were all fine until such time the pandemic hit us, and now everyone is realizing this just-in-time is something that is not clearly made for the hospital. We found that we did not have enough N95 masks, we didn't have enough masks, we didn't have personal protective equipments, consumable shortages, everything was we had to face. So hospitals are now looking for IT solutions, especially the dynamic inventory management systems, where they can look at the stock consumption, they can look at expired items, they can the stock positions in their respective hospitals also. The other concept that is coming out of this is also as you can see, the smaller organizations cannot have large stock of items, so many of them have joined together to create warehouse models, where a group of hospitals combine together to have a common warehouse where they can probably store excess of items, and then from there it gets distributed to smaller organizations as well. Other thing that we looked at, especially in supply chain management, not truly in supply chain management, but in terms of logistics, is many of the labs would have a central processing unit, where they would get samples from across the city, and probably send it across to different cities as well. So this was was a failure, where we could not send samples, especially you see where the RT-PCR was not allowed initially in all the places, in all the cities. Many of them had to send it across to different cities altogether, and logistics was one of the critical limiting factor. And now every laboratory chain and every hospital has also realized that certain of the tests which are commonly done has to be done in the local area, rather than sending it to a central located, which is quite distant from the place of collection. Infection control practices is going, which was quite neglected in earlier days, is again gaining importance, and also with less human interface. So many of the hospitals are looking for automated cleaning, are looking for robotic cleaning. So this is going to be the new normal, where there's less human interaction in cleaning processes also. A lot of checklist-driven processes, so we need to adjust towards the checklist-driven processes, which were probably earlier limited to surgical safety checklists and infection control bundles. Now every process, right from OP registration to the discharge of the patient, is now going to be a checklist-driven activity. So can we move to the next slide? So, new normal in healthcare quality. So the first question everyone asks is, has accreditation really helped? So there is no, literature to say whether the accredited hospital have responded any different to non-accredited hospitals. But from our own experience, what we can say is accreditation has truly helped hospitals face pandemic. See, there are a few features of accreditation which has actually helped hospitals face this pandemic, and also, any other situations, especially of health crisis per se. Is one is that every pandemic situations requires an integrated approach with all the stakeholders responding on the same page, be it clinicians, be it nursing staff, be it a biomedical engineer, or or a housekeeping staff. So accreditation insists on various committees like the disaster management committee, the infection control committee, the patient safety committee. So most of this, the activities are taken care by the committee, and then the committees act as a single command center, and also integrates the activity of all these stakeholders. So there is an integrated and a more rapid response. Training and development is an ongoing part of the activity of accreditation, be it wearing PPE, biomedical waste management. Likewise, during the COVID, a new concept of doffing and donning came. So it was much easier for accredited institutions to train their staff because they already had some basic level of training, and it was much more easier to do this training activity. Third one was the hospital acquired infections, the surveillance mechanism, the policies, protocols, they were all in place. So it was much more easier in accredited hospitals to face these situations rather than in non-accredited hospitals also. Going ahead, the training and development is going to gain a lot of traction, especially in a country like us where there is a lot of disparity in the number of skilled manpower. As you can see, the number of doctors, the doctor-patient ratio, nurse-patient ratio is unequivocal. This is pandemic has given a situation for us where we're looking at skilling our staff, reskilling, cross-skilling of staff. Of course, we cannot prepare an ICU intensivist overnight, but of course we are looking at a lot of skilling healthcare workers who can handle cases, handle intubations, likewise. So this is another situation where skilling and reskilling of cross-skilling of staff happened because of the pandemic. Enhanced audits, especially digital quality management systems. Hospitals are looking for digital quality management systems where they're looking for real-time analysis of the surveillance reports or the hospital acquired infections, or the number of infected cases in the ward, the turnaround time for various tests, and the critical lab alerts and all those things. They're looking for all these things. Quality management systems are going to get digital and will be a part of the new normal as well. Can you go to the next slide? And to summarize, this one good thing about this pandemic is there is a greater focus on hygiene. So the concept of hygiene is of predominant importance right from the first outbreak of cholera that happened somewhere in 1854, where they realized that hygiene was one of the important role. And now with this pandemic, this is one more good habit that the people have now been accustomed to. Personal workplace and home hygiene is will be gaining importance. As I told you, patient-centric approach and evidence-based approach will be the way forward. The clinical autonomy will take a backseat, and the patient will be seen as a equal partner in their care, and patients will be more empowered with the knowledge repository that is also accessible to them as well. So we have to get prepared for the patient-centric approach with the empowered patient being in the center of the healthcare decision making. One thing that we realized is in the recent years there was over specialization of healthcare. Patients with headache would go to a neurologist. Patient with chest discomfort would go to the cardiologist directly. And this is where COVID taught us that, okay, here is a situation where your first access is a family physician. This is going to gain importance in the coming days. The concept of family physician and public health will re-emerge. Digital healthcare will gain more traction and acceptance, as I was talking about, and there will be a more unified approach to public health emergencies. Earlier, it used to be the provisional or a country-specific approach, but now there will be a more unified approach to public health emergencies. There will be a demand for quality and quality of healthcare, transparency in functioning of the hospitals. And to conclude, as Darwin's theory says, the survival of the fittest and the mechanism of natural selection, it will continue to govern our survival. And it is important for us to realize that the best of the medical facilities, the best of the consultants or doctors cannot help us in situations like this. So everything depends on us, and how healthy we are is truly dependent on us. And this is the realization that has come to everyone, and that will be the part of the new normal. So with this, I conclude my talk, and I once again thank all of you and all the audience for giving a patient listening to my comments. Thank you.
Thanks, Dr. Arun. It was very insight. There's a lot of insight that you threw upon with respect to medical services and the clinical operations and quality. So we come to the first interjection point where I just want to ask all the other panelists, what are going to be the big challenges at the clinic level, the so-called OPD clinic, especially the single doctor clinic? How are these single doctor clinics going to function in this new normal world? Can I have Professor Dr. Ashok Tyagarajan go for it first?
Yeah, thank you, Rajarajan. Yes, this is a big challenge. Even in fact, I could see the patients are asked to come with a newspaper. They have to sit on the newspaper. They have to bring it. Then after seeing the doctor, they have to take it and throw it off. And some doctors, they're using a screen, nice screen. You have to stand on the other side, and then from here he asks questions, and you have to do that. So this is regarding the facility and the management of the OPD. But in terms of improving the patient care services and also utilizing whatever the facility what he has got is going to be a very big challenge. And the infection is rampant and it's going up like anything. So there are two things. One is that how he is going to project himself. Second thing is that how he is going to facilitate the process of patient care management with the small space and also with the limited areas and also the convenience what he has got. The best thing is that following the best clinical practices and also infection prevention norms. Thank you.
Yeah, thanks. Anybody else who would like to add on to that? So, Dr. Vijay, anything on telemedicine, how it is going to change the practice of clinic level practices?
So basically, Raj, at a clinic level, the space constraint and crowding is one of the major factor in India. If you go to a small pediatrician, there would be 20-30 kids waiting with parents and stuff. So now the major challenge there is how do you segregate the crowd? The first thing, at least of late, most of the clinics which I have observed is most of them are encouraging patients only on appointment basis. They are avoiding random walk-in, and also the assistants are calling up and just checking if there was any pre-symptoms of fever or kind of COVID symptoms and stuff, and then accordingly giving them appointments. And most of the doctors now they are preferring to give a teleconsult, and only if it is absolutely required they're asking the patients to come to the clinic. And mostly again there are issues with hygiene and stuff, So most of the small clinics and hospitals which had split AC and stuff, they're trying to up it, go without a AC or just have a natural ventilation kind of thing, so that there is a proper air circulation or kind of thing which is maintained. So I think all these challenges would be there. So slowly facing it and mostly segregating your patient and attendant flow. Where you're having a clinic at 200 or 250 square feet, it is not so easy. So some of the clinics which were doing sample collection at their clinic level have stopped because of the poor hygiene practices of staff, and they're also encouraging for the home sample collection. So these are some infrastructural changes which the small time clinics are adapting.
Yeah. And over to you, Ramesh sir. Do you think the cost of consultation at a clinic level is going to increase? Recently, we had news about one of the famous salon chains, Naturals. They've gone on public saying that they're going to charge something like a hygiene charges, and they're presenting it on the bill. And the company representatives also have gone public to say why they are charging that, to give a safe environment for people. So, do you think our patients are ready to actually pay that extra 200 bucks if the single doctor clinic charges are 200 rupees currently, or even 100 rupees? Are they ready to pay that extra 200 to 250 rupees, which would go up in the coming days due to various PPE usage at various levels, and pulse oximeter level check, and the various other things associated with it? So the cost of consultation, is it going to go up?
Yeah, definitely, Raj. Ultimately, in any business, any consultation, ultimately the end user pays. So here, a patient cannot be an exception. He has to pay. Here, I only, the scenario what we have, what Vijay envisaged, what Professor Ashok envisaged, we are talking about urban kind of a setup. If you look at, if you slightly move away and go to semi-urban and rural areas, trust me, nothing like social distancing, and things are as good as ever, which I have recently witnessed while in Gujarat. I was just going not far away, about 60 kilometers from Ahmedabad. There was nothing like a social distancing in a clinician's, in a general practitioner's clinic. It was full with 60, 70 patients waiting outside and stuff like that. So if you people have still not come to terms with the danger of what's going to happen to them if they don't adhere to this. Coming back to the urban setup, many of general practitioners are yet to start their practice, at least in the areas which I know here in Gujarat or in Chennai, or some of the friends whom they do the general practice, and most of them stick to the teleconsults, and most of them prefer meeting them with appointment, and many funny things like a screen in between, and maybe you sit inside the room and see the patient on a monitor. I mean, a patient who is waiting outside your OPD is being seen on a monitor. All these things are happening, but nothing has been standardized. No guideline has come from any say forum, say be it IMA or be it the ICMR or be it any other monitoring agency. None of them have really come out and said this has to be a OP setup. So to answer to your question, whether the cost is going to go high, yes, it is going to go high. To what extent, we really do not know. It can be 200, it can be 500, or we don't know. But definitely healthcare is going to be expensive, which I think one has to be prepared.
Yeah. Thanks, Ramesh sir. Dr. Arun, from the doctor's point of view, what do you think is the mindset of the clinic doctors now, and why do we see there is a resistance for them to adopt to a technology like teleconsultation or telemedicine, even after the government has released the telemedicine operating guidelines in the month of March? Can you just unravel that for us?
Yeah, certainly. Like, as I told you, telemedicine is something that was available earlier, but because of certain regulatory constraints, it was not very used actively. And second thing is that since it was only used during the time of pandemic, both the patients as well as the doctors were clearly unprepared for that. One is that, as I told you, telemedicine or a teleconsultation, even otherwise, is now only for a repeat patient and only for a patient with minor ailment. So it is not allowed for a new patient, and also it is not allowed for a for diagnosis of a complex medical condition. So this again and also further advice on the medical management of the patients. And second thing is that especially in a surgical situation, telemedicine is found to be wanting, where a doctor cannot probably see a lesion, he cannot do an examination to find out where the pain is, and he cannot appreciate the nature of wound. So these are some of the drawbacks that we saw in telemedicine. Nevertheless, as I said, there is a growing acceptance both among the patient as well as doctors, primarily for chronic disease management, especially among we have seen more acceptance of this among endocrinologists, among the nephrologists who would probably look at some of the lab reports and ascertain whether the patient is okay or not okay. To that extent, it was. But now, since the OPDs have started, there is a bit of a decline in the teleconsults that we see. But as I told you earlier, it also depends upon the interest shown by the patient as well as by the doctor. If the patient is has a trust in this particular system and demands that, so doctors and hospitals will certainly have to continue with this particular technology.
Yeah. Hello.
Yes, I can.
Thank you. Yeah, I lost you in between there, Dr. Arun. But thanks for the response for the audience. We will talk about the challenges in hospitals as we go ahead in the final panel discussion. Without further ado, I would like to call upon my good friend, Dr. Vijay.
Yeah. So, can I start, Raj?
Yeah, go ahead, Dr. Vijay.
Yeah. So the topic for me was healthcare infrastructure and project management, but just wanted to talk on new norms related to this. So this is a very vast subject which cannot be covered in a small time. But because of the need of the hour, I thought we will just I'll just talk a few things about planning a high-risk area. Now most of the hospitals will be forced to, or already in most of the metros where the infection is rampant, the hospitals have been forced to take up COVID cases also. So how do you manage hospital infrastructure during this situation? So basically, when there was a shutdown announced and a lot of things were happening, we had a lot of calls coming up as an infrastructure consultant to what to do, how do we create a isolation zone, how do we have negative pressure rooms. See, most of the times when we insist in our planning that the importance of negative pressure rooms, compartmentalizations, and airlock, most of the hospitals or most of the people, they tend to neglect it because the number of AHUs or the number of infrastructure required to manage this airflow is very high, or the kind of infrastructure cost is high. But most of them felt the need of that at the present situation. So I thought I'll just take everybody through how do we just get into a high risk area planning. So first of all, we need to have a location identification, because most of the hospitals are based out of a single building or a vertical building, All hospitals do not have a luxury of having multiple blocks or multiple buildings. In a large scale hospital where there are multiple blocks, or you have different standalone buildings, converting one of them into a high risk area is easier. But how do you do it when you are a standalone building and stuff? So identification of a location where do you want to keep your high risk area is one of the key factor. So then second thing is what's the kind of the space allocation which you need to do. So if you are a 20,000 or a 30,000 square feet hospital, a small 50 bed or a 70 bed hospital, how much can you allocate when you have only 3 OPDs, only 4 OPDs, you have only 2 OTs or a single complex, or you have a general surgical ICU and a general medical ICU. So how are you going to allocate the space? So these were the challenges which we could face when we were reviewing plans of smaller hospitals to make them more compatible with COVID thing. So here we had to take a call and convert few of their general wards or few of their single rooms or a semi-private room, breaking them and merging into a small 4-bed or 5-bed ICU, and then making it a negative pressure and converting it. Then also some mandatory facilities needs to be planned, which needs to be taken care when you are planning this high risk areas, especially your change areas, your what we call your housekeeping closets and stuff, your AHU area, and your one-way traffic. So these flow of material, flow of people, flow of patient, all those things has to be done. And the zoning requirements is very important because like any other regular situation, you can't keep allowing everybody to walk in and walk out of a particular ward or a thing. So how are you zoning, which is a restricted zone, which is a patient area, which is the attendant area, and all those stuff. In my next slide, I'm just going to explain all these things. And internal air quality is one of the biggest challenge which most of the hospitals are facing, especially hospitals which has got centralized AC, which do not have natural ventilation, who have not gone in for a HU kind of setup, or who cannot segregate the airflow, or who cannot put a HEPA filter. So there are a lot of challenges kind of thing. So mostly fixing a terminal HEPA, having an exhaust HEPA, these are the small kind of solutions which you can bring in to cater to the health of the air there. Then again, the key challenge is your interior finish and infection control. Most of the hospitals which do not have the required finish, what kind of wall treatment are you going to do? What kind of the floor treatment are you going to do? And what type of the ceiling treatment you are going to do? These are the small things which you need to consider when you are planning a high risk area. Next slide, Raj. Yeah. So some of the salient features in developing high-risk areas in a hospital is infection prevention and control. So the infrastructure planned to be incorporated during planning phase itself. It is not easy to convert any given place overnight into a negative pressure room or a critical care area or stuff. Unless a meticulous planning has been done, it is not easy. But in spite of that, we are trying to change and help to convert, identifying the very feasible space and helping them to convert. Then hospital buildings must meet the standard quality of ISO 900 and ISO 14,000 series. Old building renovation should meet required standards as per the type of healthcare facility. Segregation of different areas in the hospital based on the risk of infection. So admin area, non-admin area, clinical area, semi-clinical area, support services. How do we plan them? How do we segregate the flow is again the key thing. So minimize cross-infection through isolation and proper ventilation. Your air isolation, your physical isolation, your traffic isolation are the key things here. Minimum entry-exit to control infiltration of the infectious diseases. So most of the hospitals have now restricted the entry from multiple gates to a single gate. Nobody can enter into the hospital directly. They have to pass through a chaos where the checking has to happen. Even the patients are screened initially outside, and then they are allowed to get in. Raj? Yeah, sorry. So requires zoning of critical areas like surgical suites, ICUs, your catheterization laboratories, your CSSD and stuff. When there is an emergency case which is landing at your ICU, you will not be able to assess at a time if there is an emergency PTCA or if there is an emergency delivery. How are you going to take it in a hospital unless your infrastructure planning is in place? You don't know at the time of emergency, when a patient walks into emergency, whether he is a COVID positive or not. Do you have a dedicated OT where you can take all this dedicated cases? So most of the hospitals which had OT in their emergency wards have been lucky, because most of them have converted those emergency OTs into a negative pressure OT or a COVID OT kind of thing, where they are able to take a highly suspected case and still treat them on the emergency case. So patient, staff, and attendant safe environment. So most of the small hospitals and nursing homes which were housing resident doctors, nurses in the same building or the same campus, the kind of things now has to be changed. It has to be relooked. Their circulation has to be relooked. Then future proofing to avoid expansion. So mostly at this COVID situation, hospitals are trying to do a makeshift arrangement, but a makeshift arrangement will not help you on a long run. You would end up spending again and again or double the amount in this makeshift thing. So whatever hospitals need to get into, even if it is taking a bit of time, they need to exclusively plan, keep the future requirement in the future, and then invest. Then private rooms, location of sinks and airflow designs have resulted in 10 to 11% decline in overall nosocomial infection. A simple act like putting a wash basin or a hand sanitizer out of each of the room, or next to two beds in every ICU, it has brought down the it has brought the infection rate to very minimal in most of the hospitals. Yeah, Raj, next thing. So common design interventions to reduce infection at this particular junction is a permanent patient screening facility at the entrance. Most of the hospitals have adopted, but again, this can be improvised further. Instead of even a manual infrared gun, people can upgrade their technology for infrared cameras, which can read the temperature and alert you on a monitor. Because most of the time the handheld infrared guns do show a right reading or don't, and there is no quality check or what we call a standardization on these equipments. And also the movement of patients or attendants through this kiosk, where the entry of all their details and stuff would be taken care. Then next, coming to floors and walls should be seamless, getting onto a antibacterial paint coating, or getting onto a vinyl wall paneling, getting rid of porous materials on your flooring pattern, or going for a vinyl flooring, which are antimicrobial and which are anti-static kind of thing, which avoids lot of joints or corners. This will help for keeping the hygiene of that place. Then mostly upgrading your clean room infrastructures, like your doors, trying to get into a automatic or hermetically sealed doors, which will have touch sensors, which can avoid a lot of physical contact kind of thing. Then having more laminated and smooth surfaces, which can be easily disinfected either through the spray or through the regular dusting or mopping kind of thing. Then in most of the places where you can, in high-end areas where you have regular procedures or intubation or kind of aerosol generation procedures you do, preferably upgrade those room ceilings into a antimicrobial grid ceiling, which after a patient is discharged, the rooms can be easily sterilized or sanitized. And also during this moist time and stuff, most of the time we would suggest, at least in key critical areas, even above the false ceiling, grid false ceiling area, kindly paint those areas with antimicrobial paint. It gives you a lot of comfort. It avoids formation of your fungal growth and your microbial growth in that those ceilings. Yeah, Raj, next. Raj, next slide. Next, yeah. So one of the key factor is now when you're converting most of your general wards or kind of things into an ICU and stuff, there are a lot of challenges. You have a lot of your electrical fittings, your water pipes, everything which is not concealed inside, which is done on a wall. Conveniently, most of the project people, as a makeshift thing, they lay all your conduits and stuff on the wall, which is highly infectious area, or which cannot be maintained or cleaned. So mostly when you're planning these, even if it's taking more time for you, kindly insist on having a concealed pipelines and your electrical conduits and stuff in any of the makeshift areas which you are doing. Then install hand sterilization unit at all the possible places, outside your wards, outside your this thing, outside your OPDs, wherever the people, even the places like where your housekeeping, what we call the change areas, your F&B entry and exit points, all those places needs to be checked, and it needs to be installed with hand sanitizer facilities and stuff, where they can repeatedly keep cleaning their hands, which will help reduce the infection kind of thing. Then try to install HEPA filters as much as possible in this high risk areas. As of now, if you're not able to fit it at a AHU level or thing, you have an option of fitting a terminal HEPA filter, which may not be very expensive. So in most of your critical care ICUs, and even if you're having a transplant ICU and all those stuff, you can upgrade the room hygiene by having a terminal HEPA filters or kind of things fixed. Then obviously most of the hospitals wouldn't have really planned well for your segregation of your biomedical waste and stuff. It would have been wrapped in a cover or kept in a corner and then taken. So kindly identify the places where your biomedical waste can be safely stored till it is cleared, and the number of areas need to be accessible for a trolley or kind of thing, where hygienically the biomedical waste can be discarded from the hospital. Then the other thing is, the major hospitals, one of the flaw is they haven't planned a ETP or a STP kind of setup if it is a small kind of hospital or things. With today's condition and lot of pandemic and things, a thorough planning of a ETP, even if you don't have an STP, having a basic ETP where you treat all the water coming out of these infected areas, then let it into your municipal drain or get into a STP, can reduce a lot of hazards to the working staff and the people. Then the water quality also plays a key role. So installation of more and more RO points, having a safe drinking water, your what we call your automatic dispensers would help you to reduce the kind of infection. Raj, next. Next slide, Raj. Yeah. So this is a quick reference slide. No, one slide back, Raj. One slide back.
Vijay, the tabular column is on the screen.
Yeah. Sorry. Basically, this is a quick run through which you can do in any of your hospital and check how is your positive pressure or negative pressure in each of the room. So, like highly infectious areas, you need to have must negative pressure, minimum 12 air changes per hour, which is required. Then protective isolation rooms who are immunocompromised patient, but you're sure that they are not an infected case or stuff. So you need to provide them or keep them in a positive pressure room. Operation theaters, your sterile stores, all those things need to be under positive pressure. So there is a lot of debate going on whether a negative pressure OT is helping in this kind of pandemic situation. But still, most of the doctors or practicing surgeons are not comfortable with a negative pressure OT, because that attracts a lot of infection, and the chances of surgical site infection or kind of things are very higher when you operate in a negative pressure OT. Then mortuary, obviously you need to have a highly negative pressure, and mostly try to avoid keeping any bodies overnight in these places. Try to dispose them as fast as possible when it is suspected or infected cases. This is a quick reference, and please make sure that all the required air changes is maintained, all the fresh air changes has been rechecked, all your filters have been regularly cleaned and disinfected. And there is also an option that in case you don't have a facility where you can really control the air changes or the airflow in the hospital, you can look at having some UV sterilization on your return air ducts, which will sterilize the air or kill those viral particles, which would be a better to recirculate. So when you're not confident on your air change and stuff, we recommend as much as possible to have a very minimal what we call recirculation of the use there. Try to pump in more and more fresh air. You may lose cooling to an extent, but when it comes to health advantage of that, you have a lot of advantage in that. Yeah, Raj, next thing. Next slide, Raj. Yeah. So quickly, this is a broad representation of how you need to consider things when you're planning. So you have a patient entrance area, you have a staff area, and you have a ward area. This is purely, I'm talking, this is a kind of WHO kind of recommendation when they ask you to set up an infectious hospital or kind of thing. So in patient entrance area, you need to have a segregated waiting area with a dedicated toilet for them, which will not be mixed. Also, you need to have a dedicated staff area where you have your logistic warehouse, you have your entrance, separate staff toilet, your office, your changing rooms, and all those stuff. And clearly have an interface area where the doctors or the staff can triage the patient. They can do the sampling, and all your administrative or billing activities can happen, and the patient can exit without interacting or coming much into the hospital. Then in case the patient is found to be positive or it is suspected, you need to take them into the ward. Always try to segregate your ward areas also into a suspected ward, where you can't mix everybody. Everybody has to be kept in individual room or isolation. But once they are confirmed with a particular COVID case, then you can segregate them on a mild or moderate kind of case where it just requires a monitoring kind of thing. A general ward converted kind of thing would serve for it. Then you have something called as a severe ward, where your oxygen saturation levels are less, where you need a bit of higher kind of support, where you have a centralized medical gas system supply, you have a better monitoring system and stuff. Then the third area is a critical ward area, where your patient requires a ventilation or a kind of stuff. So all these areas has to be considered thoroughly. Please check the movement, please check the proximity, please check the air isolation, and then allot and plan these areas if you do not have a kind of luxury to segregate and have a separate building or a separate infectious block kind of thing. Yeah, Raj, next. So quickly, a few lines on project management. So three things have been very important for the project management during this COVID crisis. Most of the states now again may go back to the lockdown because of the rampant spread and stuff. So one is I've seen a lot of hospitals now coming and checking what kind of quality materials and stuff. Because of non-availability, they're trying to compromise on materials which can be used. I kindly request that you don't compromise on your quality of your material choice. Please stick to the recommendation of your consultants and stuff. And during this stage, the source or the certification of the material which you are buying is not verified because of the shortage and stuff. Please try to make sure and verify all the source. Try to get all the verification certificate, your test certificate. Otherwise, whole of the work or effort which you have done might have to be redone once it fails for you. Then the second thing is there is a challenge of getting skilled people because of still there is a lot of travel restrictions and stuff. Always try to get the skilled people to do the work. It will reduce or minimizes your rework or redo kind of thing. And also when you are having a workforce, try to keep them under a controlled environment, under your control, so that you will not be allowing them to be exposed to everybody and again bring back infection into your hospital. And third thing is work timelines and stuff. Either the work can be carried out parallelly when the hospital is running, then you have your own set of challenges which you need to plan and execute. Then you can shut down a particular block or particular floor, get all the work done, and then restart. So these are the common things which you need to look into when you're trying to execute the project. Yeah, Raj, next thing. So quickly here for one of the large hospital in Chennai, this was a thing done. Since it was a standalone building, they were not able to have a segregated OPD or kind of thing. So with makeshift temporary German tents kind of thing and your exhibition kind of material, quickly over 2 to 3 days, makeshift OPD, screening center and stuff, they were able to put up. So any patient who comes to the hospital, this is a part of a driveway which is being used. They will be thoroughly screened here, and only if mandated or if required, they will be taken into the hospital, or a general physician or a kind of surgeon would take a call at this OPD and segregate the patient. So this is one of the quickest thing which you can do without compromising on the quality of service which you need to give. Next slide, Raj. So this is one of the project I was proud to be associated. This one of the biggest IT company in India, as a part of their CSR activity, converted one of their IT building in one of the cities, and they have made it into a 450-bed COVID hospital, which would be now taken over by the government and run. So this was a testimonial for us, because over a lockdown period of 2 months, we were able to plan close to a 1.5 lakh square feet, convert it into a IT building, convert into a COVID hospital. So I've just put you some visuals. We didn't compromise much on anything. We were able to really give them a good 5-star kind of ambience and stuff. And we have created a few makeshift ICUs, so that the severe cases, if they go wrong, they can be stabilized and shifted to a COVID designated hospitals and stuff. A makeshift lab has been created, a makeshift X-ray and ultrasound things have been created. And there was a lot of challenge converting this place, especially when it comes to HVAC and stuff. This was a centralized building. So one of the small innovation which we could do here was we tried all kind of ventilation system, but it didn't work. So we came up with an idea where we started pumping in whole of the fresh air, cool it as much as possible through the AHU, block all your return A's, and we used all your fire windows. We kept it as open and we started exhausting the air. So we made it a semi-natural ventilation, which allowed us to actually cater to this. Otherwise, creating a HEPA filter or a negative pressure or treating all this kind of air and doing was impractical in 1.5 month to 2 month kind of thing. So a small innovation like this can actually help you to serve your patients better. Yeah, Raj.
Thanks, Dr. Vijay. That was very insightful, especially that you guys are currently working on some COVID hospital for a very big state where, due to confidentiality reasons, we are keeping, though I know of the place, we have discussed that with me, we're keeping it as confidential. But yeah, so there are a lot of innovations, especially that needs to be done. There is a lot of retrofittings which are required at this point of time in various hospitals. So those are some of the highlights of things which has been shared by Dr. Vijay. He also gave us a quick glimpse of a checklist which you can all go and check in your hospital how it is and stuff, so that you can look at where it is. But going to my panelists, uh, how many hospitals are really ready with respect to these kind of pandemic situations? Are they really ready? Can hospitals be really ready for these kind of pandemics? Because in all our NABH drills or any other disaster management drills, we have never seen a pandemic related thing. The highest being a bomb threat or a fire related thing. But this is something really new. So, your thoughts, panelists. Who's going first, Dr. Arun?
Yeah, okay, thank you. As I was telling, so in terms of preparedness, as I told you, like it depends upon a lot many other factors. The availability of resources, the availability of infrastructure, and a lot many things will tell us about how prepared we are. As I told you, this particular pandemic has sort of hit us unprepared, to be really accept the truth. But our response has so far been good. Nevertheless, our response has been good. Uh, Certainly, as I told you, this is going to be accepted as a new normal with the new pandemics that may come arise. With the lessons that we have learned to a lot many things depends upon the availability of resources, equipments, the training level of staff, and all those things. So that is something that we have engage at the next level. As I was talking in the slides as well, a lot of upskilling of staff, going towards maintaining some short supplies of equipments and personal protective equipments and all those things. Something will go ahead. And as I told you, as you yourself were telling, mock drills will now also look at the search, evaluating the search capacity of the hospital. All that is going to be the new norm.
Anybody else would like to go for it? Any other panelists? We're falling back on schedule, so shall I move ahead with the next presentation?
Please.
Okay, I'll take it as a yes. And, inviting Professor Dr. Ashok Tyagarajan, CEO of Westminster, to take over.
So thank you very much, Raj. So you better to this funda. At the end of the day, every time you keep on convincing somebody, whatever you are, you may be a doctor, you may be an administrator, you may be a teacher. At the end of the day, you keep on convincing people. So for that, you need to sell yourself. This is what I have been taught by my beloved professor. I'm a direct student of Philip Kotler. So I am wedded to this concept. So let me try to sell some of the ideas of new normal. Next slide, please. Yeah. this is the major issue that we have been discussing. The epicenter of this unprecedented global pandemic challenge healthcare is facing. And we need to think of a traditional to consumer driven healthcare model, which we are going to discuss in the next few slides. And from the patient, it is going to be the consumer. And also we need to look at the choice. What is the right choice? Whether it is a patient-centered approach or it is a consumer-centered approach or approach where 360 call, we need to take everybody into consideration and what is to be done. In the new normal, what is going to be the future? Please, next slide, please. Yeah, this is the one which I would like to look at it. Maybe we'll take some time on this. All these days, if a hospital, if you see in NABH, we say that we draw something like this always. The who is very close to the patient, and it has been always nurses and doctors. Now the new normal, and the patient is going to be the focal point. What's going to happen? So it is going to be all our lives are going to get connected to the patients, and also we have to be well organized, and it needs a prolonged approach over a period of time. So there need to be a process improvement along with the change management. That is what the slide is saying. And thanks to Deloitte, and Deloitte has dealt in detail about this process, what is going to be done. When the patient is going to be the focal point, how it is going to change, the change management, what is going to take place, and also the process management, the quality of care, and also patient satisfaction. These are the two eyes of any healthcare organization. And what is going to happen to that? And where the other guys were grouping around, if we see the government or the pharma or KOL, they are all there. So now what we look at earlier, pre-pandemic and post-pandemic, is going to be totally different, and we need to have a patient-centered approach. And it's very nice, Dr. Vijay has presented. Now, without a wash basin in the entrance, no hospital, no clinic can function. We have been trying to convince our healthcare professionals and the patients the importance of hand washing. Now, hand washing become a new normal. You need to work on the basic fundamentals of hand washing. Next slide, please. Yeah, this is very, very interesting. What is the why we need to focus on consumer? What is the traditional model, and what is going to be the consumer-driven model? I would like to touch upon the three things. Here, it clearly depicts that I'm not getting into the details of the slide, which everybody can see and they can understand. Always, there were very few things. Patient was the producer, payer, and provider. Now, when we change our approach to the consumer driven or the patient centric approach, all the other things are coming into picture. So especially two things I would like to touch upon here. One is that the value stream mapping. We all know that value stream mapping, it started somewhere in 1915 by the great professor Charles Koppel. It was known as the lucid chart. Even today, if you go around that, we teach in the colleges about lucid chart, and which is further developed in the year 1950 by the great company Toyota, how this value stream can be mapped. Today, in the modern era, we talk about the lean management. In the lean management, we need everybody. We need housekeeping, and we need everybody in the system. So when the patient-centered approach, when the consumer-centered approach, when we talk about that, how we are going to organize everything together, how we are going to shift ourselves, and value stream mapping is going to be the most important factor, where with the limited resources or with the limited interventions or interruptions in the system and also the process, we are going to provide, how we are going to provide the best quality care to the consumer. And also we need to take all the stakeholders along with us. While considering this change, when we take everybody along with us, you know that hospital is that complex system where it is a labor intensity area where you got everybody, and it's very complex operation system. You see the operation part of it when it comes to question of patient, right from the front office, security, and also the nurses, and everybody plays a major role at every point of time. In the service delivery, we talk about the encounter, service encounters. At the end of the day, we need to ensure that the service quality is the best, because all these things, whatever you say, that the past building or the infection prevention structure what you have, or the nice infrastructure and the air quality system, zoning, cordoning, yes, it plays a major role. But at the end of the day, the service deliverance and the quality of care, how it is going to impact and how the consumer is going to be happy is most important. Next slide, please. So there need to be a paradigm shift. So in the paradigm shift, how to assess, as I said, the value stream mapping, how are we going to assess, how to plan, how to implement more effective supervision. And one is that define the problem. For example, the major problem in the operation today, if you see that our normal routine has been changed now. So at the entrance level itself now, when there is a temperature more than, for example, 100 degrees, we don't allow the patient to come in. They have to go to the fever clinic. So from this onwards, up to the operation theater, PPE has become a new normal in radiology department, in laboratory, and also in the operation theater. Then these are all the things. Then when we talk about all these changes, definitely another question comes is that our inventory management. How are we going to do the operations with the inventory management just in time? Or I still remember the famous quotation of when I was working for Johnson & Johnson, I used to mention that zero inventory. Dell used to maintain that when we need something, it has to come immediately without any delay, but we should not maintain any stock, which is a very ideal situation. But the better we manage our inventory management, it is better. Today, the cash flow has become a major problem in the pandemic area, and our expenses are going in a multifaceted manner. We can't control the expenses, but at the same time, how are we going to improve all these resources or the sources in operation management by defining exactly the problem and how we are going to improve upon it? And once the problem is identified, and how are we going to implement the solutions? So as I was telling, lean management is one of the nicest thing, and a lot of theories have started coming, and every hospital is getting into research how to do the lean management. And some time back, we used to think that HR department is only selection, recruiting, training, and going ahead. These days have changed now. HR is also a profit center, and how this is going to be done. And as far as the skill mix is concerned, the need for change. One is that introducing the nice hierarchy system, because the hospital is labor intensive. So many departments are there. If you see the patient care, various departments, various professionals and peoples are coming in between, and there need to be a excellent communication and process flow which can provide the best solution. So when we talk about identifying the problem, then what are all the solutions we can do that, and what is the span of control, which is very, very important. Today, when there is a problem, you can see that everybody is jumping into that. They try to find solutions. Span of control within the department and overall the hospital level or in the management, we need to do that. We talk about, there are two functions, line functions and also staff function. The hierarchy and line function is going to be the major role. I am also mixing the operations and also the resource management here. In lean management, both the operations, lean operations are absolutely important. We talk about zero mistake. And when we talk about the lean management and also the operation, something comes today, which is a famous quote, which everybody must be aware of it. Poka yoka, or some people call us a yoka poka. Yoka poka is the one error proofing which is there. See, for example, if you see any ICU, you can see the collision of instruments. In the hurry, everybody comes. The major problem is that the people and also the equipment that comes. So how we are going to reduce the errors? How are we going to streamline this process? Yoko Poko is the one which is error proofing. We do the work without any mistake. And we also identify that A lot of research papers started coming in, and people have started really looking at it. Even though it's one of the oldest funda, maybe 10 years back, Yoko Poka has come, but hospitals, this is the right time. When we talk about the change management, when we talk about the value stream mapping, when we talk about the lean management, definitely Yoko Poka plays a major role. Planning for change, yes, we need to change everything. Change is going to be the order of the day. The change right from the OPD, how we do our work, how we move around. Handshaking was the most important thing today. There is no handshaking, and everybody is wearing a mask. And another thing, hand washing become absolutely important. And psychologically also, we need to prepare our people, the resources. We need to psychologically, we need to prepare them, including the doctors, to come out of the fear psychosis. And also the mind, once it's become very free and the mind becomes motivated, the skill levels are getting improved, the performance is automatically getting improved. So all these things are going to be useful in the period of time, and we are going to see the change in everywhere, as we have been discussing, whether it is a clinic or a quaternary care hospital or a multi super specialty hospital. See, today when we talk about the pandemic in a hospital, we have a categorization. We say that, okay, 2 floors I give to the COVID patients, and the remaining everything will be there. How infrastructure development or change we are going to make that the infection doesn't pass through, and how we are going to ensure that the circulatory movement or one-way exit, one-way entry, how are we going to manage? In places where the complex transplant surgeries are going to take place, how we are going to ensure that our operational efficiency is at the peak, wherein we ensure safety for the patient, the high-risk patients, and also the patient who come for the fever clinic. Next slide, please. Yeah. So at the end of the day, if we have to give a value, because we say that it's not a mere work. Now, as an operations head, as a P&L head, my job is not to come and just do or deliver certain tasks. What is the value we are creating? And that's what we are also working on that in QurHealth. By doing this webinar, what is the value we are going to generate or what we are going to give it to the audience? And value, quality plus services divided by the cost. You can never discount the cost. Cost is going to be there. When we talk about the value-based healthcare system, how it can be measured in terms of patient care, and in terms of patient care, how the waiting time can be reduced. Today, you see that in the social distancing, and we say that we get the pre-appointment and come in emergency, what are we going to do? And now I could see that in US they've started, in Germany they've started, how in the OPD you can reduce the time spent by the patient by 40%. That is the work which is already going on. Research is started doing, and unnecessary patient movement has to be reduced by minimum 20%. And the most important thing is that there should be an increase in space. That's what we have been discussing. In such pandemics are coming, how effectively we are going to improve the space. Already we talked about all using the gypsum board, having a temporary structure, how it can be changed. And increase of space means what they are talking about, 60% increase in a pandemic or in a situation where we need to get into faster action, bringing more patient and staff. So we need to think how we can improve 60% the space. So the data is Raj is, I think he's the boss. He talks to everybody, and that is the reality now. So what is the data we are going to use, how it is going to be measurable, what we are going to store, which is very, very important. And the coordination of services and care and the communication, very important. We always see that in the research management, there is a miscommunication. We talk about water cooler syndrome, or we talk about coffee corner syndrome, or gray point communication. In the resource management and also in the operation management, a proper, clear communication is absolutely important. When we give a clear communication, there is a better collaboration, cohesiveness among the people, whether it's a doctor or a nurse or a technician or a staff, including the housekeeping staff. They work cohesively, and there is a beautiful delivery of service. That is most important. At the end of the day, the clinical excellence has to be matched with the operational efficiency. We all know that many times what we have seen is that the doctors, they do a fantastic job, and in terms of surgery, in terms of managing a patient or ICU care or the operation theater, the clinical excellence we see. But how do you measure the operation excellence? How do we measure the operation excellence and efficiency? So the only way is that by using all these modern management tools and techniques, there is a need for immediately improving the operational efficiency. For example, pharmacy, what is the goal? People think that the goal of pharmacy is to buy medicine and just give it, but it is something different. How a pharmacy can be aligned towards your organizational strategy or goal. Example I'm saying, like this we need to think. The pharmacy is a place where all the stores, how organizationally towards the strategic goal we are going to align these people. So as we have been discussing, this is going to be the as I said, one skill or one talent what you have, which is not going to be sufficient. It's going to be five-finger mechanism. We say that all the skills, all the talents, all the opportunities should be used. So we need to talk about the value-based healthcare than the whatever data-based healthcare, or we talk about anything else. It's all value. How we are going to provide value in terms of delivering the care and also the services. Next slide, please. Yeah. So the thing is that as we have been discussing, Dr. Vijay beautifully explained the new paradigm of infrastructure. It plays a major role. We are breaking our heads how to make operation theater into negative pressure. I cannot take any surgery now. Doctor is very specific that I want a negative pressure. Maybe I need to call Dr. Vijay and I have to think of it. Geographical distribution of providers and care settings. This is going to be the paradigm shift and also the modus operandi. As I said, organize operational excellence and also the clinical excellence. It should match like two hands. It has to come together. There comes the emergence of new growth opportunities and diversification. COVID has given us an excellent opportunity. It is testing every part of the hospital and every part of our body and the brain, how we are going to change ourselves. And tomorrow is going to be the not the normal, it's going to be the new normal. I think it's a fantastic topic, and the heading what is given by Rajarajan, and it's really good. Next slide, please.
Thank you, sir. Thank you for your valuable insights, especially with the value-based care. We are running short of time, so we're not going to stop over the slide with other things. I request all the participants to start putting their questions in the Q&A section. Post our last speaker, we'll be starting with our Q&A section, and we'll be addressing most of it. Next up, without any further ado, I would like to call upon Mr. B. Ramesh. Ramesh, sir.
Am I audible?
Yeah, yes.
Now
you're audible. Yes.
Yeah. So the toughest thing is to be the last speaker when all the top guns are blazed, and most of it they've already covered, and we have paucity of time. But nevertheless, I'll try to. Most of it, I mean, it was really enlightening to hear to Professor Ashok, Vijay, and Arun. So I'm not going to really. Many of my points they've already, in fact, explained and elaborated. So that made my job easy. See, from my perspective of new normal or the challenges is from the point of view of the board of directors, how we look at it, the new business, the challenges, and as Dr. Ashok said, the opportunities. It's going to be the new buzzword is going to be clinical excellence with COVID safety. The moment, you know what, one of our multi-specialty hospitals, when nowadays you are the actual important person heading a company, hospital, you are the important person. Suddenly all the ministers, MLAs, MP, they all know you suddenly. I don't know how, but they all know you. So when they ask, first thing is, this is a non-COVID patient. Do you take COVID patients also? So the moment you say, yes, we are part of it is a COVID hospital, they just take a step back. So now what people look at us as a hospital, promoters is basically assurance that are we safe from COVID. So this is something which the healthcare fraternity is definitely will have to give that assurance to the non-COVID patients to come in. That's I see as a biggest challenge now for non-COVID hospitals. COVID treating versus non-COVID hospitals. That's the this particular line is basically because I'm seeing both the sides. We have two hospitals in Ahmedabad. One is a COVID hospital, the other one is a non-COVID hospital, and I see altogether a different mindset of people, those who come. The one which is completely a specialty cancer hospital, there literally I can see ease in the employee's face and the doctor's face. They are comfortable and they move around. Of course, we do insist our clinical management and the leadership, the unit leadership, they enforce strict, measures, safety measures. But nevertheless, you can see a kind of a ease when people walk around in that hospital. Complete shift when you move to my other hospital, where it is a 50% is a COVID hospital for COVID patients. Everybody is scared and they talk to you from a distance. They move with a lot of. So this, going back to what Dr. Arun said, but somewhere, this accreditation of JCI and NABH have really sensitized people towards basic infection control. Today, you don't need to spend your time during this critical time to tell them what is hand wash, what is hand sanitization, what is the importance of wearing a mask or cap. To that extent, in some of these hospitals which are accredited, people are sensitized. So your job never started from zero. You had some sensitization prevailing with the people. So the job started from there. If having said that, it is still a lot of teaching is required for. If you look at most of them, they hang their mask here. I mean, they don't wear it fully. We see a lot of people moving around. So the basic sensitization is done, but the importance is being imbibed into them. So we are definitely moving towards a safe working environment, but we have still not achieved the new normalcy, what we perceive as. If you look at the healthcare institutions, suddenly, if you look at 70, we see a report 70% of private hospital patients are not there. The private hospitals are working at 30% capacity. This is what we get to hear. Doesn't mean that people have lost faith in, whereas the government-run hospitals are full. Does it mean the private hospitals have lost the credibility, or the government hospitals have suddenly, with their way they treat the COVID, they handle COVID scenario, have they become suddenly a more credible alternative for public at large? That is something when we look at it, it's not so. If you look at 70% of people do not really come because they are elective. Their treatment is elective of nature. You can have a no contact advice to them, and most of the surgeries are deferred, if not cancelled. So this is all this is putting a lot of pressure on the private hospital, as a P&L as the business, the costs have doubled, whereas your top line has gone down almost to 30%. So there is a tremendous pressure on the the board of directors to come out with a revival strategy. Which we are actually have all of us done it? No, we are evolving, right? So because we really do not know how long this pandemic impact is going to be there, and what is going to, because your new normal changes every passing day. So we really are not able to standardize your new normalcy in terms of the parameters which would guide your business going forth. If you think the credibility of private hospitals have come down, is it a challenge now? That's going to be the new normalcy? No, it is only a pass. And there's some startup for people would still prefer coming to private hospitals, and government hospitals are already loaded with enough patients. The next thing is contact-free health. I'm not going to talk much about it because already Dr. Arun and has elaborated on it. For paucity of time, that's going to be the new normal going forth, which we are emphasizing. We are asking our unit heads, the operating heads, and the clinicians to move towards contact-free healthcare. A lot of new softwares and new technologies are being used, which are developed, customized for our setup, which are being put in place to handle it. And I'm sure that is going to be the new normal, which has already taken place. In fact, just for statistics, last month our clinicians have done 720 teleconsults, which is a big number. Rather, which is slightly more than what we would have done in our bad month, So that's catching up, to say so. And the other thing, what's happening is home health. I'm not going to talk much about because already many of you have touched upon. But one thing which is really interesting, all of you should note, is somebody asked me, can we give home chemotherapy? I mean, can we set up a kind of a small daycare unit at home and give chemotherapy? Some high net worth individuals are keen because they are not. We run cancer hospitals. Instead of coming to cancer hospital, despite being a non-COVID, they still have apprehensions. They are asking, can we start home chemo? So those ideas are evolving. Already 1 or 2 pilot work has been done. And again, the new paradigm is going to be value-based care, which I'm not going to elaborate because Dr. Ashok has beautifully elaborated what it is going to be. And I don't want to repeat what he said. Next slide, please. Yeah. So we see now, yesterday we had a review meeting with our marketing guys, and I was just telling them that now you should become a key account manager, no longer a marketing guy who will be doing a referral doctor management and cold calling and relationship. Rather, it should be digital. You can stay connected with them, help them out, and become their key account manager in terms of taking care of that particular doctor's patients who are with you. Become a spokesperson rather than a marketing person, because that's going to be the new normal. Because I'm sure most of the marketing guys will have to change their traditional approach from doing a cold calling and explaining, and rather in their terms detailing about the services. Rather they can do it, I mean, they should shift to digital and become the spokesperson and key account managers. And in this, as I told you, public relation is key for a hospital. Here, if you look at this is especially during this time, and with I would say we really do not know how long this pandemic is going to go along, and we really do not know what is there in the near future. So it is important we have our public relations very strong, because public relations, when I say, it includes from the board point of view, the most revered politicians. We really have to take extra care in attending to them, and the media, and because they just of course, I mean, in all good intentions, nothing, no credits taken away from them, but they need a story. And now all these stories are available only from hospitals, COVID hospitals, and whether be a nurse dancing with the patient to motivate, or a patient not given food, or anything is the news for them. And if you see one full page of COVID story from hospitals are published practically in all the newspapers. So this public relations, we wish, at least when it is unavoidable getting quoted in the newspaper, at least a good thing if it is quoted, it's at least appreciable. So your PR helps there. Extra mile. What I mean by extra mile effort, I'll tell you today to stay on. You just have to do something slightly more than what others plan to do. As I said, something like a home chemo, which others will hesitate to do. Something like picking up a patient from their area, getting them here and dropping them back safely, so that this is slightly one extra effort, which will two things it will do. One, it will infuse a lot of confidence in you. Second, that's where your operational excellence meet your clinical excellence. Your end to end, it is the patient is taken care, and to make him a loyal patient, it is important. I say, I mean, of course, we don't want patient to come back to us very often. Loyal, when I say from the brand recall point of view. So it's these small little things will make them loyal to us, and we become their point of recall at any point of time. The other thing is teach along the treatment, which Dr. Ashoka has already said. When a patient comes, a lot of teaching needs to be done. Something like when you enter a museum, people say towards your left is this, right, don't touch anything, don't spoil anything, this is the round. So this is going to be, now hospital experience is going to be like a guided tour. You need to have, at every point of time and every place, you need somebody to guide, to take them around and teach. And a lot of places we see funny videos, where somebody wants to do a sanitization spray, and one of them thinks that it is holy water. He drinks, the other guy lifts both his arms, to get sprayed deo. So I mean, people have to be taught from that level to the importance of it, and which we are seeing. Why I'm saying all this involves a lot of cost. If you look at, for a hospital of our size, or even for a much smaller hospitals, or a bigger hospitals than ours, if you look at the cost is phenomenally high in doing this, that extra mile effort, which includes teaching them, having a guide, go along. So from the board, this is for us a new normal, yes, we can't avoid it. We have to accept it. We are just working around evolving a new ways to come about. Let's see, with the time, our new strategies might come up with the solutions. Again, the other day when our board, our virtual board meeting, one of the directors, who is an independent director, asked us what percentage of market share you can take. I mean, we can really, now it's a new market. It is no longer the old market. Earlier, my international patients used to be 25%. Today, that 25% of pie is gone from you. So you have to create a new pie. So it is too early, and we just have to probably around the same patient thing. All the resources, all the hospitals are going to go behind. So you have that extra mile, your value proposition, is going to create a better pie for you in the market share, which is going to be predominantly local. So we are moving away from traditional pie, which had your 17% of international patients, some 20% of outstates patients, and the remaining local, which is now going to be purely local, and your international and out-of-state patients pie is going to be less than 10%, at least for next 6 months. For this, I would call this financial year as a COVID year. So this COVID year, you are going to have a completely different pie. Let's be prepared. Of course, digitalization already Dr. Arun has done. So we are some silver lining. Ours will be the first. Healthcare industry is going to be the first riser from the setback, because people are just waiting to come. So a good, safe environment and increased trust level, and the one extra mile approach is definitely going to get your loyal patients back to you post this fear of COVID. I'm not saying post COVID, post fear of COVID goes, which we anticipate anytime between September to October. We don't know. It's not going to be COVID free. I'm just saying post fear of COVID. Then a lot of focus will now be, with so much of awareness, so much of alternative medicines are being explored as a option. A lot of people are now looking at the preventive health segment, which will see a major boost, and I'm sure this is going to be a big your no contact health and your preventive health is going to be a bigger pie in your outpatient income, which we envisage, and our revised tweaked business plan is going to be in accordance with that. And we envisage the new normal is going to be 200 rupee or 500 rupee OPD is going to be 200 rupee more. Now it's going to be 700. And we have to, as a board, what we have asked our unit leaders is to come back to the revised business plan, where 30% lower top line and 10% lower EBITDA. That means we are working on cost optimization. How do we do it? It's a big, probably that is going paucity of time. I don't have time, but of course, all the leaders who are here, they know the entire industry is working towards that. Next slide. Yes, so it's going forth. Transfer of records, digital transaction is going to be on the increased side, and I'm sure Raj is going to, probably Raj's industry is again going to be the biggest beneficiary of this digital transaction. And we need to look at the loans and advances, which we have to rework, restructure to reduce your interest burden, which is very, very important. And going forth, all the investment should be really looked at, which is now not going to be free for all takeovers, and a lot of what I research is a lot of polarization will happen, a lot of integration will happen, a lot of takeover. I mean, a big group taking over a smaller, relatively smaller group. All those things would happen post COVID, probably in the next 18 months. This is what we envisage. And we need to work on a shared resource model that makes your company asset light and become better, you get a better ROI. And most of the non-core manpower should be, in my opinion, outsourced and optimized, so you have a better accountability and better control on cost over a period of time. And of course, there will be a lot of spending on infection control practices, which is going to be the one established new normal. So next, please. I think I'm already running out of time. Yes. From the compliance point of view, this is in fact there is a lot of complaints which I'm sure all the panelists would know. We have a lot of complaints, new complaints which have come to the local panchayat office, to the municipal corporation, to the state nodal, to everywhere, and non-reporting or non-compliance of all these are today is considered a violation of Epidemic Act, and I think the stress is on the board and the unit heads who are running it, and which I'm sure is now going to new normal, which we all of us are gearing up for. And the other, we have something called compliance report, which the managing director will have to submit to the board. And I'm sure going forward, this is going to be the new normal, new compliance, which we the workplace assessment on their safety and hygiene is going to be the next new normal. As a board, we will, and this will enhance the scope of audit committee. I'm not going to talk about revenue assurance because that will take a lot of time, Raj. Maybe some other time, because it calls for a lot of explanation. And as I told you, we have to reduce this high time. All of you are unit heads sitting here. If possible, wherever we should reduce the debt and, if possible, work on refinancing options, which all of us are working on. And the last line item, salaries and pay cut. We have not gone in for any major reaction. Of course, we are watching out. Maybe I would, and a lot of companies have gone in for salary cut. That has given them a greater cushion for their, I would say, their cash flow for at least temporarily 2-3 months. And today, Supreme Court has even supported the employers. I mean, you don't need to mandatorily pay all your employees, and government cannot enforce. This will give those companies where there is no business, only cost attached, some relief to them, and this will help their cash flow predominantly and reduce their liability in terms of salary. Yes. Slide, please. Next slide, please. So it's now the focus will shift from function. I mean, it is no longer the function of HR or a function of operations, function of, now it is going to be how that function performs efficiently. What Dr. Ashok said, same thing. The process used functions for better efficiency is going to be the new buzzword which the board will look at, and strongest controls possible to ensure cost optimization to revenue recognition, third revenue realization, which is very crucial for the days, at least for next 12 to 18 months. As I told you, then from the board point of view, the scope of audit committee is completely enhanced. It is going to be redefined, and anybody from the board who is in the audit committee will have to bear more responsibility. And finally, it is maybe it may be on the lighter vein, but it is definitely going to be EBITDA. Your EBIT, EBITDA, looks good, but the C brings a small dash before EBITDA, negative EBITDA. So what we need to really do is to handle the effects of the C to come back, neutralize, and move forward. And with the suggestions came from Dr. Ashok, Dr. Arun, Vijay, and I'm sure people like us who invest in hospitals are looking forward for support of all these gentlemen, and we make again the healthcare industry most investor-friendly industry in the country. We are looking forward to that. And I knew I rushed through because of paucity of time, a lot of places where I couldn't explain, but some other time I'll be happy to take all your queries, if any. Thanks, Raj.
Thank you, Ramesh sir. It was pretty interesting the way you went on detailing the various factors which are going to be key for brand equity, marketing, and also the business as a whole, and from the viewpoint of the board, how it is going to be. Before we draw close to this, before we get into the Q&A, I just wanted to say, as a 80s kid, when we started growing up, we always saw 2000 has going to be the big problem year because of the digital transformation that we started early 90s. We were always worried about something called as a Y2K. And you know what? It turned out to be all right. We didn't have any major issues. Probably the solutioning was arrived at and stuff. And post that, when I was finished college, when I started my college and all those stuff, everybody started talking about Vision 2020. And honestly, we all know how Vision 2020 is. It has been, though it has actually been very not so good on various factors, but it has brought together people, brought together something which we had forgotten called hope. And that is something which Vision 2020 has really made it possible. So what we think can go wrong has not gone wrong. What we thought that could have been all that great is not all that great, but it has really taught us all lessons. And so with all those lessons, especially from our panelists and speakers today, for the wonderful inputs on how hospitals or healthcare organizations as a whole can cope to these new normal perspectives was wonderful. Behalf of all the participants, 250 odd participants who had logged in to our session at various points of time, I thank you all. We'll just quickly go through the questions. May I have all the panelists, switch on your webcam and also switch on the, unmute yourself. So the first question is about telemedicine or virtual consultation. Any ethico-legal dilemma in prescribing of medicine and treating of patient? Dr. Arun, would you like to go for that?
Sorry, I could not hear the question properly.
Telemedicine or virtual consultation, any ethico-legal dilemmas in prescribing of medicines and treating of patients?
Yeah, certainly. As I was mentioning earlier, the whole crux of a doctor-patient relationship is the face-to-face the patient that allows the doctor to make a more informed clinical judgment and decision, and also the feel by the patient of having been examined by a patient. So this builds a confidence in both the doctor as well as the patient in terms of the decision that the doctor makes, and also the acceptability of this decision by the patient. Now with this virtual scenario and the telemedicine thing, this relationship is not built. So this definitely gives rise to a lot of dilemma for both the parties in terms of how do they actually approach this particular the encounter. And apart from that, as I told you, like the technology is not a very realistic thing. So you can't clearly do a lot of assessments which could possibly do by by matter of vision or by examination, other things. So there is a lot of things that the doctor might miss, which would probably lead to a wrong diagnosis, wrong clinical management of the case. These are telemedicine and a virtual experience for both of them.
Yeah, thanks, Dr. Arun. So next question we'll have for Dr. Ashok. So Dr. Ashok. how insurance companies going to cope up with the new COVID packages introduced by hospitals? Anybody else in the panelists would like to take that? Ramesh sir?
See, yeah, I mean, it is nothing new. I mean, COVID management is basically either. Yes. Yeah. Can I? There is a lot of echo. Yes. Am I audible? Am I audible?
You're audible, sir.
Okay. Yeah. See, COVID. See, there are two ways a COVID patient is treated. A normal COVID patient is treated like any other basic flu treatment for any other basic flu or any other normal infection. And the other one is most critical, who needs a oxygen to ventilator. So this is nothing called COVID package. It is like any other critical care treatment or any other normal admission with observation. So I don't think insurance companies will have any need to be feared. Yeah, the volume may increase their, which they are going to cover the next year in their premium. I don't think insurance companies will have any undue fear now.
Thank you, sir. Thanks. So the next question is, fear of COVID is not allowing IT corporate employees to visit hospital for complete health checkup and other screening, which was good source for hospital for elective surgeries. How to increase the awareness to break the fear of visiting hospital and screening? Dr. Vijay, would you like to go for that? Dr. Vijay?
Sorry, yeah. Well, in one of the hospital which I'm associated in Chennai, we have not seen drop in health checkup. Now, retrospectively, the healthcare IT companies are pushing employees to get a health certificate or a health checkup done completely at a recognized hospital before joining the company, to come physically and attend the office. So I don't see there is a fear of that. There is a good number of health checks happening, good number of things even for the patients who wants to fly out now internationally and stuff. There's a lot of requirement for your health check and stuff. It will come back. It's only a matter of time. Once people get confidence in your brand or in your hospital that you follow all protocols, you have infection control things in place, I don't see that you will lose this health checkup things.
Yeah. Thanks, Dr. Vijay. We certainly believe that. Yeah, Ramesh sir, would you like to add?
Yeah. This situation.
Panelists can jump in.
Yeah. This situation will continue for at least next 2 months till the time public at large develop confidence in going to hospital. So suddenly there may be some exceptions like the hospital which Vijay is associated with, but generally people have stopped coming for health check. In my hospital, it is zero last 1.5 months, and I am sure Dr. Ashok is agreeing with me.
Yeah. So the next question is about, are hospitals considering redistribution?
Dr. Ashok, I think Dr. Ashok's mic is muted. He has to unmute.
Yeah. Now, Dr. Ashok, would you like to add something on that, Professor Dr. Ashok?
Two things I want to tell you. One is that regarding the ethico-legal aspects of telemedicine. Say, as a lawyer, I can tell you that a lot of hitches are there. So there comes the role of the electronic medical records. the electronic prescriptions and medical records, a lot of medical legal cases will come, as Dr. Arun has rightly pointed out. One thing is that I think recently the leading hospital, the model corporate chain of hospital, they started implementing very nicely regarding the digital records and also the e-prescriptions and also the complete record. And they are able to integrate the records of the patient if they are already existing patient with the telemedicine. So it's slowly pushing towards the teleconsultation or video consultation over a period of time. And another thing regarding the insurance, already I was told by leading insurance companies that they are getting into loss already. There is a huge loss. They say it's all because of the current situation where the hospital bill is around 3 to 4 lakhs per patient if they are getting into the ICUs. So as the panelists rightly pointed out, like we face problem, all our service provider, whether they are the device manufacturer or insurance companies, they also have problem. Hopefully the hope is expected by the end of the year. Thank you.
Thanks, Professor Dr. Ashok. For want of time, we will close the Q&A session with that. I would like to go one round with all the panelists, the speakers, to give their closing comments. And after we'll close, we are going to answer all your questions offline and send it across to you people, along with the slides for reference, the video link, the e-certificate. So just bear with us. Over to you, Dr. Arun, for your closing comments. Dr. Arun?
You have to unmute.
Yeah. Yeah, Dr. Arun. Dr. Arun, you can go on.
I think his mic is muted.
No, from my side, it is unmuted.
Yes. Only my mic is on and Mr. Ramesh mic is on.
Dr. Arun, can you speak?
He's speaking, but
No,
we are not.
his mic looks unmuted. Sorry, muted. Yeah.
The boss is having the control. Please use it.
Yeah. I have unmuted. For me, in my screen, it is looking green. Dr. Arun, for your closing comments.
Organizer now.
Yeah, now go ahead. Dr. Arun, you're now only audible, so please go ahead.
Can you hear me now?
Yeah, please.
Perfect.
Yeah. Thank you, one and all, and thanks to all the fellow panelists. It was a great learning experience. A lot of knowledge was. Yeah, I think this is a difficult scenario for all of us, for doctors, administrators, hospitals alike, and I'm sure, there'll be a day where we are really prepared ourselves to face this pandemic. And only thing what I can say is, this is something that is that has happened. Probably going ahead, as I told you, we need to have a very unified response. A lot of sharing of knowledge has to happen, and all of us have to accept health is the primemost thing. And whatever the policy reforms, whatever be the budget allocations, whether it is private allocation or public health allocation, a greater amount of importance has to be given towards health. And this is what my concluding remarks. Thank you.
Thanks, Dr. Arun. Over to you, Dr. Vijay, for your concluding remarks.
Yeah, this is a hard situation. Hospitals have actually got into a very tight cash flow situation, but still you cannot get out, or you cannot get out of spending on the requirements of infrastructure, so that you can start taking in cases and provide a better facility. So I think a right planning and right decisions would help you to move further. Plan for future, don't plan temporarily, don't compromise on any of your services or any of your limit, And for all the healthcare workers, stay safe. We all are doing a good job, I'm sure, and hope to overcome this situation collectively.
Thanks, Dr. Vijay. Over to you, Professor Dr. Ashok Tyagarajan.
Thanks, Mr. Rajarajan. Hope you are able to hear me. Okay. First of all, thanks to you for having arranged a clinical by Dr. Arun, infrastructure by Dr. Vijay, and the most important thing regarding the finance and marketing by Mr. Ramesh. And of course, with all these things, you need operations and resources. And it's a very well thought, maybe an iconic figure like you can put it, think like this, and you can make it really very good. There are two things. One is that the COVID situation has given us the idea where we are weak, wherever there are gaps. The gap analysis we are able to see. Number two, it also gives us the strength of expandability, where we can expand. So we have identified a gap. We have also seen where we can expand. With this, the future is going to be fine. Only thing is that people have to be brave, and especially healthcare workers like us, because every day we see the second or third person in the hospital is getting infected. We need to be very strong mentally, physically, physiologically, so that we can overcome this. Thank you very much.
Thanks, Professor Dr. Ashok. Over to you, Ramesh sir, for your closing comments.
Okay, let me start with two, silver lining. One is there are more recoveries than the reported cases in India, which is a good thing to note. I'm not getting into the strings attached to it, but this is what we hear and we believe, and we are happy about it. And second is healthcare industry is going to be the first one to come out, because people are just waiting. They just want the gate to open and they will rush back to you. Hang in there. You have not lost anything. Yes, you are into a temporary situation where you have become the, one of the panelists said, now the hospitals are the epicenters. Yes, we are the epicenters. We are facing the brunt of it, but I think collectively we will come out of it. And this industry is going to be the first one to recover. With that note, I thank Raj for having arranged this wonderful discussion, and I am happy to have met other panelists, and I thank all the attendees who were in good numbers, 100 plus who were there, and till the end, some 75 are waiting even to listen to our closing remarks. I'm happy about it. Thank you. Stay safe. God bless. Thank you.
Thanks, Ramesh sir, and thank you all, audience. You've been a wonderful audience. You've stayed with us throughout. Thanks to all the 252 people who have logged in and logged out at various points, and the remaining 74 who are still holding on to us. We have further exciting programs coming up. We have something coming up in 2 weeks on masterclass webinar on customer centricity and design thinking for healthcare organizations. We also are looking forward to do healthcare workers mental health, with all the status of affairs around us, how we can cope up with that. So that is also in the coming weeks, and probably the early next month. So we really look to have you all for that. And our panelists, our expert panelists, have been wonderful. They've been here throughout, giving their insights, and thank you, each one of you. Thanks, Dr. Arun and the entire Ramaya team for helping you put together such a good show here. Dr. Vijay and Integra Ventures, thank you. Professor Dr. Ashok Tyagarajan and Westminster, thank you. Ramesh sir, CBCC and the Apollo CBCC Cancer Care, thank you. And from us, from QurHealth, from GMI, and from Ventech Solutions, I take great pleasure in signing off from you. Thank you all. Hopefully it was a very, very good, knowledgeful session for you all. Thank you all. Thanks.
Thank you.
Thank you.
Thank you. Thank you, gentlemen.
Thanks.
Thank you.
Thanks, Dr.
Thank you.